Okay, good. So we are now recording and I will get started. So welcome everybody on this lovely winter day to talk about our hearts. I wanted to talk about atrial fibrillation today and stroke prevention. If any of you are new to me, I am Carol Penfield. I'm a nurse practitioner. Been one for a long, long time, since the 90s, and I'm a lifestyle medicine specialist, board certified. So really my specialty is helping people prevent and manage medical conditions without medicines and without surgery. Just how you live your life day to day directly affects your health. So I'm going to talk today about these medical conditions, and will always finish with what you can do to help prevent all this from a lifestyle standpoint. So atrial fibrillation, as you'll see on that screen, there is a electric impulse, our EKGs, which show how our hearts beat.
Right.
You got a P wave, you got a QRS, and a T going through there. So that's a normal rhythm strip right there, just for kicks, if anybody's wondering what that all means. Everybody okay? Everybody's with me? All right. So here we go. Okay, so we're going to hopefully go forward. Why is that not? Okay, our first little jam up here. Here we are. Okay, always good to start with the heart. And since we're going to be talking about the heart quite a bit, always great to kind of review our anatomy, physiology. On this, we're going to go into a little more detail in the next slide, but on this slide, just sort of showing you have blue and red here. So it's representing the two chambers of the heart, or four chambers actually. The blue area is the unoxygenated blood coming in and then pumping out to
Does this running bother you?
lungs. Nothing's bothering me, if anyone's asking. Everybody okay? All right. And the red is showing oxygenated blood going out to the rest of the body. So as you'll see here, if you look in the blue section, the pulmonary veins, pulmonary artery, and right and left atrium. So just a quick refresher, artery, A for artery means it's going away from the heart. So it's going somewhere from the heart. Veins bring the blood back to the heart. A, away from the heart, veins coming into the heart. You have your right and left ventricle, your right atrium and your right ventricle, that's the right side of your heart, and then it gets pumped out. And then on the left side, the red sections, you'll see you've got your veins, your pulmonary artery, your left atrium and valves. So there you're having, again, the blood going away out of the, towards the left pulmonary arteries, and then veins, meaning that the blood is coming in from the lungs. So I'm going to show this again on the next slide because just talking it through probably isn't quite as clear as this. So let's look at the left side of the screen, looking at the pathway. So now you've got arrows here to sort of help you here. And when we get talking about atrial fibrillation, it's going to matter what's going where and when. So you're having the blood, the blue arrows are all coming in from jugular vein, from your pulmonary artery, your vena cava, etc. So it's coming back in from the body, needing oxygen. That's why it's looking blue. Comes into the atrium, that top little section there, down through the base of the heart, the ventricle, and then it pumps out the pulmonary arteries to the right and the left lung to go get oxygen. Now the blood collects oxygen from the lungs and it comes back in through the heart now we're coming back in from the red section, and then it coming in from the pulmonary vein, and then it pumps out from the red section to your aorta, away from the body to feed the rest of the body, and up to your carotid arteries and subclavian arteries going to your arms and to your head. So everybody okay with that? So it's coming in, needing oxygen, gets pumped to the heart, collects oxygen, pumped to the lungs, collects the oxygen, comes back in the heart, and then pumps out throughout the body. So we're going to be focusing on that second part, coming in from the lungs and being pumped out to the rest of the body. So now let's look over at the screen on the other side. And you'll see at the very bottom, the aorta. Remember, A means away. That's the blood being pumped away from the body, from the heart, and going to where it needs to. So it's going to come up that artery, that carotid artery, mostly. That's where 80% of your blood supply to your brain is going to. That's why we all hear about the carotid artery studies and so forth. So that's the 80%, at least 80% of your brain is being fed by that artery there. And that's going to, we're going to probably talk about that a little bit later too when it comes to strokes. All right, everybody all set? So now we're all up to date on our anatomy. Let's talk about, let me just see if I can get this to go down. Okay, so let's talk about atrial fibrillation. So what atrial fibrillation is it's an electrical issue. It's an irregular rhythm that begins in the heart's upper chambers. So let's look again at the right versus the left picture. So those atriums, the atrias, are those top two chambers, and that's where this irregular rhythm happens. So it's really an electrical impulse abnormality. So we'll step back for a moment on what that means. You'll see in that left picture, you see where it says SA node, that top little yellow dot. That top little yellow dot, that's the rhythm, that's the metronome. That's what's in charge of giving the electric impulse so that the rhythm is established for your heart to fill up, pump out, fill up, pump out, fill up, pump out. Then it communicates also electrically to the AV node a little further down, which helps tell the bottom of the heart, the ventricles, to pump the rest out. So you have the fill in, the fill down, and then the pump out. So these two nodes are in charge of the electric system. Now, if you look to the right, the electric impulses become irregular in atrial fibrillation, chaotically irregular, not just fast, but very chaotic. And now you can see those little circles there. So what's happening now, that metronome, the boss, that SA node, which is giving you your proper rhythm, is not able to communicate that to the AV node. And so now parts of the heart get excited and irregular. And so now you get this fluttery component happening in the top part of the heart. Now the heart can't effectively pump out to the rest of the body. And you'll see in the rhythm strip above it, it shows, those little chambers are trying to do it, and boom, all of a sudden you get that big spike. The bottom is able to, the ventricles are able to pump the blood out. So it's a chaotic rhythm pattern that causes atrial fibrillation. Okay, so what are those symptoms? So left side of the screen, extreme fatigue. When not just your typical fatigue, but all of a sudden you're like, oh gosh, I can't even go up the stairs, or I just need to sit down after bringing in those groceries. It's a big change. So what's happening is the rest of your body isn't effectively or efficiently getting the blood supply it needs. So it gets very, very tired. Feel the heart palpitation, you kind of feel that in the chest or in the neck. And rather than just the anxiety flutter, it becomes more of an irregular beat. The beat is fast. It has to be really quite above 140 or so for it to be true atrial fibrillation. Atrial flutters can be a little slower, but it's an irregular, rapid heartbeat, which we'll talk about a little bit on how you take your own pulse. Shortness of breath. Again, your body's not able to get that blood to the lungs to fill up with new oxygen. So you're saying, oh gosh, I just can't seem to catch my breath. Dizziness, because now it's not going up those carotid arteries into the brain as effectively as it typically would. And often there's some near fainting occurring, and even some people can feel some chest pain. So it's sort of good to know what to do in sort of these circumstances. If someone all of a sudden feels kind of lightheaded, woozy or something, I mean, it's always good to sort of check the pulse. You can learn a lot from just checking a pulse. Is it regular? or is it irregular? And then we'll talk about that in just a moment again. So risk factors are a little more broad. My opinion is that atrial fibrillation is sort of bad luck. It is just a rhythm issue, but certain components of your circulatory system can contribute to it. So one is having a high blood pressure. So those blood vessels aren't, the integrity of the blood vessels aren't up to snuff quite as much. Coronary artery disease, so the blood's not flowing through the arteries that feed the heart well. Heart failure, when the heart's not pumping as well as it needs to. Heart valve issues, so it's not closing behind, so the blood might be regurgitating before it gets pumped out of the chambers. Hyperthyroidism, meaning overactive thyroid, where people have a racy heart and high anxiousness. Obesity plays a role. And of course, there we always have it, age. We have to blame age on everything, I think. But these are risk factors, but truly atrial fibrillation sort of is, I think more so might even run in in families a little bit more. I tend to see a little more trend in people who have had atrial fibrillation genetically. What also stirs up atrial fibrillation can be becoming dehydrated, having an infection, or fatigue, or just sort of not yourself, electrolyte imbalances from a recent illness. Some of those can stir up atrial fib. They don't cause it, meaning all of a sudden give you this new diagnosis. But if you have the diagnosis, those are symptoms that can make it stir up. So stay hydrated, avoid infection, try to have your electrolytes in balance, and sleep well, trying to avoid fatigue. Okay, so I wanted to just talk a little bit about checking your pulse. I often teach people tend to get nervous with checking their pulses, and I tend to say, put a bunch of fingers there, so one of them's bound to feel something. Sometimes the thumb, you'll pick up your pulse from your thumb, so I recommend using your fingers. So if you were to just go on the side of your Adam's apple or down just the side of your neck, and you put those 3 fingers right there, you may want to try it and just see if you can pick up the pulse. I find it a little easier to find on the side of the neck, or you can do the same by putting your fingers along the base of the thumb and try to pick it up there. Now, as we age, our blood vessels are smaller and a little weaker as you go away from the heart. So you often can pick it up a little bit better on the neck than you might necessarily on your wrist. So you want to really get an idea of the rhythm. You want to really stay there for 30 seconds and count. So a fast pulse would just be going bump, 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 bump. Atrial fibrillation would be bump, 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 bump. So they get the idea. They're regularly irregular. And your pulse should run somewhere between 60 and 100. Some people are on blood pressure pills that might have a slower heart rate. Some people just might run a little higher strung and have a higher heart rate. So between 60 and 100 beats per minute are considered in normal range. Okay, so there are some types of atrial fibrillation. We have the paroxysmal atrial fibrillation. And what that means is it's episodes that last less than a week and they go away. Sometimes you'll get this weird flutter that may last only for 3 or 4 seconds or an hour and then go away and not come back. But if it's persisting over a week's period of time, that's when you have a higher risk for atrial fibrillation. So atrial fibrillation should not go on for too long. You want to really work with your doctor in reference to, gee, if I have my atrial fibrillation for more than blank period of time, should I be going into the hospital to get it addressed? And you have more of the persistent atrial fibrillation when it's lasting more than that 1 week. And those folks are at much higher risk for stroke, which I'll explain in just a moment. And then there's specialized treatment, which I'll also explain in the next slide. So they really need to slow that rate down first and not get it so rapid, going blah, 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 blah. and trying to also get the rhythm under control would be your first bet. So it shouldn't go on for long periods of time. Again, check with your doctor in reference to that time frame of when it should be evaluated. Theoretically, it should be less than 24 hours. If it's really going on that long, then you really need to have it addressed. Okay, so let's see. Let's look to the right of the screen here. I'm going to show, you're seeing the heart again across slice. We're going to talk about medicines and treatments, but I just want to let you see that left atrial appendage. We're going to talk about that in a moment. There's this little pocket. Think of the appendix at the end of at part of your intestinal tract. Same in the heart, there's this little appendage here, and that's where the tricky part is about atrial fibrillation. We'll talk about it in a moment. So now you get this irregular heart rate. How is it actually diagnosed? So down the bottom of that screen, it's usually confirmed by EKG at the moment. So if you're having that funny irregular beat, it's good to go get an EKG at a walk-in center or somewhere while you're having your symptoms. They can easily evaluate where is that chaotic pulse rate coming from and what's happening. And the other is if it kind of comes and goes and doesn't last long and it's really hard to predict, they'll have you put on a Holter monitor or an event monitor, which is electrodes that go on your chest, and you just have the device with you for about 2 weeks. And they just continuously take those those EKG electric evaluations of your heartbeat and look at it over time to see what the trends are. Okay, so medications and then treatment, which we'll talk about with that appendage. So first and foremost is if people are at risk for a stroke, which is a clot-forming stroke, then blood thinners to prevent that clot is important. Now, I'll come back to it. Let me go back to blood thinners for just a minute. For our blood thinners that people go on when they're on atrial fibrillation, when they have a history of atrial fibrillation, all of those new medications out there, and that's to prevent a future clot. But there also are ways to treat your risk at the time or a stroke clot, which we'll talk about later. So Coumadin, heparin, and then all of your newer medications, Eliquis, et cetera, are there to help thin the blood so that you don't get a clot. Because what happens is in these top two these atrial areas where there's the chaotic fluttering going on, that what happens is the blood doesn't effectively pump out of the heart, so it sticks around there for a while. And some of the blood may pool into that appendage, and then it forms into a clot because it's not being flushed out all the time. And that's where the clot formation occurs, and then it shoots out to the body and will go, as we talked about, away from the heart into that coronary artery, into the carotid artery to the brain and cause a stroke. So you're at risk that blood sitting around too long in that atrium and that flutter causes that clot to then dislodge. So that's why people are put on blood thinners, to prevent that from happening. Secondly, there's beta blockers and other medications just to slow the heart rate down, because it's pretty intense having a racing irregular heartbeat. So at least trying to get it slowed down with a beta blocker. And then there are medications that work on helping try to regulate the rhythm. A lot of these medicines make people very fatigued. So the atrial fibrillation making you fatigued, the beta blocker can sort of slow you down and make you fatigued. And then anti-rhythm, the rhythm medications also can cause people to feel fatigued and just not really feel that great. A lot of people don't like necessarily being on the medicine. So there are alternatives. So some of the treatments, the first is that if that atrial fibrillation has been chaotic and is not going away, you don't want to wait too long for it to pool into that appendage. What you do is then go into the ER, and they will do what's called an electrical cardioversion. And what that is, they stop the heart, they put you, they sedate you, they stop the heart for a minute and restart it, hoping to get rid of and try to recalibrate and hope to get you back into a normal what's called a sinus rhythm, that SA joint, SA node, a normal sinus rhythm. So the next is, if those aren't working and people are going into the ER and having cardioversions and they only last for a day or two or a week or two and they keep going back into A-Fib, then it's considered time to look at treating the cause of the atrial fibrillation. What they have found is the pulmonary veins. So those are the blood vessels bringing the oxygenated blood back to the heart, that blue section there. Often they find that that area coming back into that right atrium causes the chaos. So there's areas of that pulmonary vein that are causing that flutteriness to happen, so that they can go in there with a catheter, go find their way up through the blood vessels, go in there and either cauterize or freeze the foci or the areas that they feel are causing that chaos to happen. And 1 or 2 times doing that tend to really get rid of the atrial fibrillation. It kind of scars the area so that there's no chaotic rhythm pattern happening. And thirdly is they often will close that appendage. So that little area, they'll put a basket in there or they'll close that up so that people are not at risk for shooting a clot from that area and causing a stroke. All right, that was a pretty heavy slide. So as I already mentioned, complications of atrial fibrillation is a stroke. So now you understand that clot formation can dislodge and travel through the blood vessels and then get stuck in a smaller vessel in the head, where which would cause a stroke. So just for a moment here, let's just step back and say, okay, strokes can be caused from many other things, which we'll talk about in a minute, but it's always good to sort of remember what those symptoms are in case you're in a situation with someone all of a sudden losing their balance, getting a headache, getting dizzy, or they're finding they're losing some visual sight in one eye, or maybe even both eyes, but it typically tends to be on one side of the body. Or they might show a facial droop all of a sudden, or just kind of a slurred speech or change in their speech patterns, or weakness of the arm or the leg, difficulty speaking, as I just mentioned. Any of these, time is of the essence. So it's very, very important that let's just see how you do. No. Call 911 and get it evaluated as quickly as you can, because the quicker you get treated, the more chance you have of recovering. So I can't say it enough. Don't worry about being embarrassed if it isn't this or isn't that. No one dies from embarrassment. It's best to get there and have it addressed as quickly as possible, calling 911. So there are other causes of stroke, and we're going to start with A over on the left. And I found it kind of interesting that I took this from the internet because I like the pictures here, and they spelled thrombotic wrong. So I put that in there underneath. Thought that was kind of interesting, but nonetheless, I can spell wrong too. So there's 3 different types of strokes. Most strokes, 80% of strokes, are caused from a blockage, which is A and B. So let's talk about those first because they're much more common. So you have your thrombolic or thrombolytic plaque that dislodges. So what happens here, you see the yellow on the blood vessel. That's the plaque buildup. That's the calcification. That's the cholesterol. That's the fatty inflammation that's occurring and building up plaque against the wall of the artery or vessel. And behind it, you'll get a backup of the blood. And the blood can also cause a clot there. The other here is that could be pushing against the plaque, and all of a sudden that plaque disrupts. So the thing here with the plaque disruption is that's what saves lives. If that plaque is new and dislodges and you get treatment quickly and immediately, then we stand a chance of dissolving that plaque and that clot and you recovering. Now, these old plaques that we find from different ways of evaluating, different studies that we do that show you have plaque formation. Some of those older plaques, believe it or not, tend to be pretty stable and don't necessarily dislodge as much as your newer ones. So that's why it's always important to work towards keeping heart healthy habits, because it's all that newer plaque buildup, which are the bad actors. So here, that's a thrombolic episode. So you have that plaque which dislodges and starts traveling through the bloodstream until it gets stuck in a vessel that's smaller and can't let it keep going. And that can occur on its way up to the brain through that carotid artery. So that's why we do carotid studies, ultrasound studies of the carotid arteries, looking at how much plaque is there. How much buildup is there that could dislodge, travel up into the head, and cause a clot or a blockage? So if there's a blockage of blood supply in that one area, oxygen can't get there, new blood can't get there, the area dies, and that's where the symptoms of stroke occur. So if you're already feeling symptoms of a stroke, then that's already gotten to the area, and the area is already starting to lose blood supply and oxygen supply. That's why speed, being quick to respond to all of this. Next one over, again in the same category where you have a blockage, but this would be a clot blockage. Now, we may have heard of pulmonary embolisms, which is a blockage, is a clot formation that travels to the lung. You could have a deep vein thrombosis, DVT, which is a clot that forms down in the lower legs. So often that's from the blood not moving regularly. That's why exercise and movement is so important. It doesn't have to be fancy, but just not sitting for long periods of time. Same with the head and the heart. So blood is always moving through, everything's moving and sweeping on, and all is good. When you, in this situation, you have the slower movement and that clot forms, and now that clot travels and again moves until it finds a smaller vessel and causes a blockage. So those A and B are 80% of strokes, much more common than your bleed stroke. So your hemorrhagic stroke. So what's that showing? That's showing your red blood cells and a change of integrity of the lining of your blood vessel. So there's a break in the blood vessel that causes a bleed to occur there. So an area of the brain starts to bleed. It doesn't get oxygen. It doesn't get proper blood supply. The area dies, causes the same symptoms. This is less common and more common with injury and falls or poor integrity of your blood vessels, which we will talk a little bit more about. So bleeding strokes, not as common as your clotting and blockage strokes. All righty, I am unable to see if there's questions or anything on my screen right now, so I apologize. I'm just going to go through all of this, but we'll get to questions at the end if there are some. Okay, so testing and treatment for acute stroke, meaning a sudden stroke. This is all sorts of rigmarole on the left, but these are all different imaging of the brain showing different sorts of things. The very bottom right, where there's two red arrows and there's a little white spot there, is called, it says post-stroke there. So what happens here when you're having imaging done is, when is it going to pick up a change? Sometimes getting the MRI or the CAT scan at the beginning may not always be quite as inclusive. Might take a little time. So for a bleed, for the bleed to collect, for the clot, for an area to die off to be able to be seen. So we have CAT scans, which are sort of fancy three-dimensional X-ray type of style of looking. And then we have MRIs. CAT scans tend to be quick and easier to do in an emergency setting. MRIs tend to probably be a little more thorough and pick up a little bit more going on if there's if they want to take a good look and a good imaging of the brain. Secondly, okay, so here we're back to those antithrombolytic drugs, the clot busters. So if there's a question of stroke, there is a clot busting medication called TPA. It is used only for emergencies where they feel that there's a sudden clot occurring causing an acute stroke. In the hospital, they can give that to you, and it has to be really within an hour or two of symptoms. That's why it's very important to get there fast. It's a tricky little medicine. It doesn't have an antidote, so you have to really be under a proper supervision for that, and that will take care of the clot at the time. The heparins, the coumadins, the Eliquis, all of those medicines are preventing future clots. But if you have an actual clot at the time, that has to be taken care of in a hospital setting. Very important to keep your blood pressure in check. And I'll give you guidelines a little later. Hopefully 120/80 would be ideal. But blood pressure, meaning that the volume of the blood is pressing against the wall and the lining of your blood vessels. Any pushing there can cause a bulbing or a weakness, and could also lead towards a rupture in that blood vessel, causing a bleed. Also, any damage from fat and stress and poor intake can cause plaque formation in there, and that blood pressure pressing against that, also causing irritation to the blood vessel wall and causing future buildup to occur. So your blood pressure is really important for preventing stroke. Well, if there is a clot there also are options for surgery. They can look under fluoroscope. They can look and figure out how to get to that clot and go up through the blood vessel in their fancy ways and go on in there and pull it out. It's really quite something. And then if there aren't lucky enough to be able to get to it acutely enough, then there are your treatments for managing now with that area of the area of the brain not functioning to its capacity. So that's where physical therapy, occupational therapy, and speech therapy are involved. So physical therapy, working with your body quite a bit. Occupational therapy is really more your day-to-day activities, working with your hands, managing your motor skills, and then speech therapy in case there is a change in the facial droop or ability to talk. Most of your benefits will occur, your gains will occur in the first year. So you have to really get after that hard in that first year to make as many gains as you can. Okay, so let's talk about preventing all this, shall we? So first of all, as I had mentioned before, controlling your blood pressure. So there's lots of ways to do that. Some are, taking fluid out of your body so that there's less volume of blood, taking some of the fluid out so there's less pressure trying to push through. So if you have a skinny tube, your blood vessel, and you've got a lot of volume trying to go through, that's going to put a lot of strain. So there's lots of different medications. Now the thing with blood pressure is it often takes 2 or 3 medications to get it under control. Getting your blood pressure under control involves different aspects of getting at why your blood pressure is up. Fluid buildup is just one of them. One would be vasodilation and vasoconstriction. One is central nervous system ways of working on the blood vessel wall integrity. Another would be the way the heart pumps the blood through. So it's fancy stuff. And as you probably know, a lot of these medicines are now in combination form. So you can, take one pill, it does 2 things. So don't be surprised if you need 3 medications to get your blood pressure under control. It's fairly common, but of course there's lots of ways to do it without medicine. So nextly is getting your cholesterol levels under control. Now our guidelines for American Heart Association have always been 200, getting a total cholesterol of 200 or less. But actually that is a kind of a low bar, shall I say. Stroke risk can still happen. What they found that if you can get your cholesterol below 150, you have a close to zero chance of having a cardiac incident. How do they know that? Well, they studied folks in Uganda, and they did over 1,000 autopsies, and there was no heart disease in these folks, and they were able to trace back and look at what their blood cholesterol levels were, and they were all in the 150 or less, and they had no heart disease. So that would be a wonderful guide for us. That would be ideal. It's my goal is to try to, I'm at 160. I can't quite get at 150, and that's without medicine, but it can be done. It just takes a lot of work, but it makes a difference. Quitting smoking, absolutely. I think probably everybody at home and everybody at the COA knows that smoking is bad. It affects the integrity and the lining of your blood. And excuse me for just one moment. Okay, I'm back. All right, minimizing alcohol consumption. Nobody ever really likes hearing that too much. We always thought, okay, well, 2 drinks a day. For men, okay. For women, it's 1 drink a day. But for true heart risk, heart disease risk, and stroke risk, they are now recommending zero alcohol consumption. That doesn't seem too fair either. But they have found when they look back at studies that when they look at people who didn't drink at all and people who did drink modest amount, they were healthier. But what they realize is that non-drinkers really had a history of drinking. So if you took the non-drinkers that never drank before and compared them to the modest drinker, those folks are healthier. So that data is out there, but that doesn't sell wine and beer and commercials on TV. So we're kind of the last to know on that one. Exercising regularly, can't say enough. We talked about how movement was so important to get that blood flowing so it doesn't sit around too long and clot. At least 150 minutes a week of activity above your normal activity. This is just distinctly for exercise and for your health. It could be divided up 10 minutes, 15 times a week. It could be 50 minutes 3 times a week. So you can look at dividing that up any way you wish. Normal weight, we're just going to move on past that one because that always makes people's eyes roll. But certainly keeping your weight in a normal range called body mass index of 25, trying to keep in a healthier zone, in a non-obese zone will help with your heart health. And controlling your blood sugar. We didn't talk about this too much yet, but certainly having high sugar in your blood does irritate the blood vessel lining. It does make your blood supply and your other organs having to work a little harder. So really keeping your blood sugar down. It used to be 120 for a fasting blood sugar, FBS fasting blood sugar, but they really want you now down at 100. So we've learned that getting up there at the 120s, even though it's kind of high, is really going to be damaging to your blood vessels. Just like the cholesterol, we have a goal that really should be lower, even lower. So with the blood sugars, that's helped a lot at diagnosing diabetes early in the game. Managing your response to stress. I would like to say I would like to remove all the stress out of your lives, but unfortunately it doesn't quite work that way. But how we perceive our stress, how we manage our stress plays a role. So stress will constrict those blood vessels and cause the blood flow to be interfered with. So trying to relax, deep breathe, yoga, all those sorts of things. But your basic, most simplest de-stressor is your breathing, because you can actually calm yourself through your breath. It activates your parasympathetic nervous system, your calming nervous system, rather than that sympathetic nervous system, the fight and flight, constrict the blood vessel situation. So dilating your blood vessels directly related to your control of your breath. So breathing in, 2, 3, 4, and out twice as long. 1, 2, 3, 4, 5, 6, 7, 8. In for 4, out long and slow for 8. You can do it anywhere, anytime, and it'll be a great help to keeping your blood pressure down. And lastly, evaluate or treat for sleep apnea. But they've made a very direct correlation with stroke and heart disease with folks that have sleep apnea. So what happens at sleeping at night, the oxygen's not able to, your breath coming in isn't, gets compressed, so you can't get all that oxygen down into the body. And now your body's trying to manage with less oxygen coming in, putting a strain on all the systems in your body. So being evaluated with a sleep study, having a positive pressure mask that pushes that air into your body so that you're getting enough oxygen. So that's an important one to have evaluated. Now, last but not least, never least, is your lifestyle changes. So there are other things you can do to prevent stroke. I'm just going to touch on some of the ones that we kind of went over. I put caffeine here. Now, caffeine is really more for the A-Fib folks. So back to atrial fibrillation rather than just stroke prevention. Generally, caffeine can constrict your blood vessels and can irritate an irregular heart rate and can speed up a heart rate. Doesn't cause atrial fib, but can aggravate it. Sodium and salt. So remembering that water travels with sodium or salt. Water travels with it, and if it's going to travel with it, it's going to stay in your blood vessel. Now you've got that volume of fluid again in that little hose, that blood vessel, more volume than the hose can handle, causing high blood pressure. They also have shown that sodium or salt irritates the lining of the blood vessel, the endothelium, the inside of your blood vessels, that will lead towards increased plaque buildup. So it's not just fluid volume, but it also can play a role in the plaque buildup. That kind of goes without saying. And all fat can lead towards a fat buildup, both around our waist and in our blood vessels. But more so, if you're going to take the big bad boys, getting trans fats out and all your animal-based fats, your high saturated fats are what you want to really decrease. And your diet really should be less than 20%, ideally 10% of what you eat each day. Alcohol, we've already talked about, less is better. All right, let's go to the positives. Let's finish with some great things you should do. So beets. Now, beets are interesting. They have shown that they've increased athletic performance and they help naturally dilate your blood vessels. There's a way that we can make what's equivalent to what's called nitric oxide. Maybe you all remember hearing about nitroglycerin, you know, the pill you put under your tongue to dilate your blood vessels if you have chest pain or angina. Beets actually can help activate that same component of nitric oxide, a vasodilating technique. So the more beets you can eat, the merrier. Wonderful. Your dark greens, remember you've probably heard many of my lectures about kale, and everybody says, well, what is it about kale? Again, kale has been well studied. Chewing your kale and eating at least a cup of kale a day also helps dilate your blood vessels and improve circulation. Also helps keep the blood vessels nice and squeaky clean along the sides, nice and slippery so that blood can move through quickly and easily. Soluble fiber. So that's your grains. So oatmeal is your best example, where that helps take your cholesterol and your fat and kind of moves it through your body and gets it out of there. So it's sort of an intestinal broom and a fat removing broom. And then lastly are your blueberries. So back to antioxidants, which decreases the stress on your body and helping with oxidative stress, meaning that you're not going to have those free radicals, those bad acting cells in your body ready to go. This will help snuff down the action of those bad acting cells. So it really leads towards a healthier lining of your blood vessels as well. All righty, so let's see if I can bring in the crowd here. All right, I'm going to leave it on this screen. I think everyone who probably can see me still. I can see you. And I'd love to answer any questions. Just unmute yourself. If you have anything, I kind of went through a lot of stuff there, and everybody feels their hearts are healthy. So, so that's generally it. If,
Audience. There's one here.
great.
You said something about the increase of blood pressure caused by fluids, and I drink a lot of water a day. Is that, I always thought that was a good thing.
Great. I'm glad you asked that. Absolutely. Absolutely. The thing about our fluid intake is that the body knows what to do with it. So the more you drink in, it takes the water that it needs, because 80% of our body is water. So it's not just blood vessels, but the cells in the body, the skin, the everything, the kidneys, everywhere is working with water. So the more water you bring in, the body says, oh, thank you for new good water. We're going to excrete what we don't need, all of this extra hanging around. So it's kind of flushing you through, and your body will know what to do with that. So if you don't have a high sodium diet, meaning no salt, no added salt to anything, then you're good. And fluid is will not bring, just drinking fluids will not bring your blood pressure up, unless it's, you know, straight vodka or something. But that's a great question. So keep drinking. I'm so thrilled that you are drinking lots of fluids.
Would you define medically what cholesterol is? I've never quite understood it.
Cholesterol, yeah. So cholesterol is something that our body makes. We need it for the lining of the cell integrity, the cell walls of a lot of parts of our body. We do need a little bit. So our body does, the liver does know how to make it so that we have enough healthy fat in our bodies. So our cell, like I mentioned, the cell lining needs fat. Our brains actually need a little bit of fat, and throughout our body. So our body can make cholesterol, but the problem is too much cholesterol gets collected and settles into our blood vessels, the extra.
So that is cholesterol also something that we take in by eating?
You can, yes, you can take cholesterol in by eating, you make it, but you also can consume it. And typically cholesterol is found in animal products. So your beef, your chicken, any animal product will have some cholesterol in it. And even coconut has cholesterol in it. And I think, you know, fish has some cholesterol in it. Some nuts have cholesterol in it. But just try to keep that down as best as we can. But your best bang for your buck is to avoid animal products that have the highest cholesterol. The other thing is they have high trans fats, and that's also a sticky fat in our bodies. We know how to take it out of our baked goods. We've learned how to take it out of foods that we make, but our animals still have plenty of trans fats in them, and that's also very sticky fat. Like cholesterol can be, and can clog up arteries.
Thank you.
Yeah, sure. Good question.
I'm surprised you chose beets. It's the only vegetable, well, greens, but there's such an array of vegetables, but you really put beets at the top of the list.
I did. I chose not to overwhelm you all with lots of things. I thought you could look at this list and do pretty well and say, okay, I'll have oatmeal in the morning with blueberries. I'll have some beets on my salad at lunch, and then I'll have kale for dinner, and I'm good. These have been well studied. It's more so probably that they've been aggressively studied. That's the problem with vegetables and fruit, is there's no money in studying, you know, foods that are readily available to all of us. There's more money studied when people have sort of a contraption or a supplement or something else that they can sell you and try to talk you into. So it's not too sexy to just eat more beets, but the science is really there, really significantly for athletes, for beets and vasodilation. They also show that this list of 4 is also very helpful with neuropathy, helping dilate the blood vessels that feed the nerves in your feet. So there's data there. It's interesting. But so I just picked the big boys.
Good to know.
Yeah. And you know,
I love beets, but I'm going to pay more attention to it because of what you said.
That's exactly what I was hoping for. And, you know, beets can be kind of messy to make, but you can buy them shrink wrapped and already cooked. And you can throw a beet in a smoothie and it makes a delicious smoothie with your blueberries or your banana or what have you. Is a great way to get it in if you say, well, I don't know if I really want to eat beets, but maybe I can try it in a different form.
Actually, I'm kind of lazy. What I do when I get beets is I will cut the top off about 1.5 inches so it doesn't bleed too much. I throw them into a steamer. I steam them. And then I let it cool down till I can handle it with, I put gloves in my hand, disposable gloves, and you can slide the skin off and you're ready to go. It's pretty
That's great.
simple.
Good point. I'm glad we've got a group here that can learn that trick now. Thank you. That's
Yeah.
great. Was there another question at the COA? Was there someone else with their hand up? It's a little hard for me to see the screen, so. Or just unmute yourself if you have a question, or if you don't, prefer not to ask in front of other folks. You can always reach me, Carol M. Penfield at gmail.com. So I'm trying to remember what I know you're there, Adele. I know you always know what I'm talking about next month. I can't change my screen right now to tell you what I'm talking about next month. I usually look it up before I speak with you all, but the last Tuesday. Hi, Adele.
Hi. Yeah, I think it's on balance.
Balance.
Yeah.
Oh, wow. That's a good
It's
one.
on balance.
That'll be a good one because we don't just wake up one day and say, I think I'll fall today, you know? So we will definitely take that on, and you'll all have a nice little program that you can do on your own, but also understanding what affects our balance over time, because we all notice our balance isn't as good as it was when we were younger. So, and the reasons why and what we can do about it. Thanks, Adele. So that's the third, it's the fourth, it'll be the fourth Tuesday at 1 o'clock. So that's the last week of February, which is perfect. I think I chose that because it is slip and fall season.
Yeah, good.
This was great, Carol. Thank you very much.
You're welcome.
Great.
Thank you.
Thank you.
That's good. Very, very.
Bye.
Thank
All
you.
right, you're very welcome. Did you have a question, Al?
Yes, is olive oil a good oil to use?
It is one of the best oils to use, olive oil, canola oil, because it has less of the cholesterol and less of the saturated fats, but it still has just as much fat as a bad fat. So it's still 100 calories a tablespoon, still artery clogging in its own right, but less of the evils. But the key here is still to, even though it is olive oil, to still not use too much of it. Good question. Yeah.
Okay.
Well, that's about it.
That's about it. All right, everybody. Thanks for joining in, and I will see you next month, I hope.
Thank you.
Bye, Carol.
Thanks again.
Bye.
Thank you.
Carol.
Bye-bye.
Bye, Adele.
It's good. Yeah, yes, very good.
Oh,
She's a-
bye, Chris. Bye, Chris.